think most of you have done it, have solved the rapid reporting set. Um, some of you submitted it today, and that's why I did not get the feedback. But many of you did have the uh, had issues. So what do you guys think? Does anyone wants to present it as a small case?
Can I try?
Yeah, sure.
So I'm presented with a frontal radiograph of a pelvis.
Mm-hmm.
I can there is a the left femoral head appears to be sclerotic with some lucent areas,
Mm-hmm.
giving evidence of avascular necrosis.
Left femoral head, you said.
Yeah.
Is there no that's okay actually. Is there anything more striking? So whenever you have a radiograph, especially when it's of a pelvis, you need to think of it symmetrically. So for example, if you look at the pubic rami here, and if you look at on the other
Okay.
side, you see there is a lucency
Lytic
here.
lesions are there. Yeah.
Yes, yes. So when you have a doubt like that, you can actually play with the windowing, and then it will become more obvious. So does anyone have any doubt with this one? So well try, Dr. Shankar. We'll move on
Yeah.
to the next one. So
Yeah.
okay.
Metastasis
Yeah,
left.
so yeah, you can just mention the lytic lesion. You don't really have to uh, give differential in case of rapid reporting, isn't it? Or you can write
Yeah.
2 3 differentials like a lytic lesion. It could be primary or metastasis. But most important thing is you mention it is on which side it is, and
Mm.
you also need to mention um, what what kind of lesion it is, whether it's lytic or sclerotic. But those are the important things, like anatomical things. And yeah, so we'll move on to another one. I think if Dr. Weisley is here, he should take this case because he made me read something on like I needed to go online to find the differential he wrote. So do you want to take it, Weisley? Yeah,
Wait a second, can you hear me?
yeah, I can hear you. Yeah.
I've searched back my diagnosis. I'm it's not the same as this one.
Yes, but do you want to, for the benefit of others, can you tell what did you think and why it is not that? So
So in this lateral knee radiograph, there is a bony fragment that is separated from the patella because we see a depression over the inferior part of the patella,
yeah,
and it's likely a patella tendon rupture with a fracture over the patella and pulling back this fragment inferiorly. Initially, I'm thinking about something like a Sinding Larson Johansson,
oh
but it
yes,
should be overlapping with the insertion point of the tendon over the patella.
yeah,
It
agreed.
should be the case.
Also, in that one, I went and read with your Sinding Larson Johnson syndrome. You don't really get the fragments there, do you? It's more of a soft tissue injury. You and it's basically, I think, chronic traction injury of osteochondral junction. So on X-rays, you will just get the Hopper's fat pad getting blurred or not. In this case, you have the fragment here, so it's just a simple thing. It's just a avulsion. So
And
that's
the
what
age,
I yeah, so that's what I try to tell you guys, like think simple things, like I know, like you guys are all learned and you want to give big differentials, but you need to think that this exam is for registrars, third level registrars, and uh, it's for simple things. It's not going to be complicated questions there. So think of a simple differentials first, especially in rapids and in viva, and then go on complicated things. Sometimes in long cases you can get some complicated things because you need to merge 2 or 3 findings and then give a differentials in case of long cases, but otherwise think of simple things. Yeah. So third case, does anyone want to speak up? uh, I think most of you got this
Fracture,
one.
fracture distal phalanx. Of
Yes.
yeah.
So some people were asking about the proximal as well. This is old. This is the old injury. So, and that's acute one. So if you write one of them, you will get full marks. In exams, this case will not be an exam, because in exam you will only have one abnormality. It won't be two. Yeah. So, okay. So this one was a bit difficult, and yeah. Who wants to take it? Just I think someone else other than Dr. Shankar should try now, and wisely. Alan, do you want to take? Catherine, uh, Nidhi, I think G and K. I don't know what that stands for, but yeah. Does anyone else wants to attempt this?
Sir, can I take?
Yeah,
I'm Bhavya.
yeah,
So
yeah.
I presented with a frontal radiograph of right foot. I
Mm-hmm.
see soft tissue swelling in the right toe with mild erosions in the distal phalanx of the right third toe.
Okay. Here.
Actually, there's osteopenic changes.
Yeah.
Osteopenia, with soft tissue swelling. The rest of the bones appear normal. The bone density appear normal. There are no fractures or dislocations. The rest of the bones.
So what do you think it is?
Osteopenic changes with soft tissue swelling. There are no soft tissue calcifications.
Mm-hmm.
Uh, and mild erosions on the distal phalanx.
So
Um,
in rapid, you will not get such a long case. So it's going to be just one abnormality, and that's what you need to write it down. So where do you think is the most prominent abnormality? I agree there is a bit of osteopenia going on and other things, but what is the most striking abnormality here, which I'm pointing at? So you look at the
soft tissue.
end here, yeah. Look at these ends, and
Yeah.
look at here. That's so if I really play with the window, you can see there is some bony fragments around, yeah, and there is a soft tissue here. So what is really going on here?
Could be infective, like osteomyelitis.
Yes, very good. So that's actually that's osteomyelitis of a third toe distal phalanx. And why you call it osteomyelitis, because you have this kind of destruction which is more like diffuse. It's not really um, it's not like some lytic lesion of like metastasis. It's more diffuse, and there is some fragments around. So it's yeah, it's osteomyelitis. But even if you have return fracture, it will still be acceptable because you have picked up the abnormality. And yeah, good. So we'll go on the next one. So just shout it out. I think this was one of the simple ones. Does anyone wants to describe it?
Pathological fracture left right lesser trochanter.
Yes.
Troc-
Why do you say it's a pathological?
Uh, because of the bone is also, it is not the young age, it's old age, and also there is a lytic lesion seen,
Yes.
and as well as
Good.
with fracture.
Good. Yeah. Okay, let me admit. Uh, yeah, I think Dr. Noah is here. So yeah, so it's a pathological fracture there, and there is avulsion. Okay. So the next one. What do you guys think? Remember, this is rapids, yeah. So some cases can be,
Look,
yeah,
Normal.
yes. So the key with the rapids is once films goes up, and in first 15 or 30 seconds, if you don't see, uh, that's going to be, if you don't see any obvious abnormality, that's going to be normal, yeah. Okay. What about this one?
Looks
Normal.
normal.
Yeah, good. So you can actually contrast this one with the first one which we saw. You can see symmetrical. Yeah, there is a symmetry between two on the normal one, and on the first one you had the lytic lesion there. Okay.
I had a doubt in the first X-ray, the one on the right.
Sure, sure. You always should ask down. That's why we are doing this. Tell me.
Uh, in the sacral region, what are the soft tissue opacities? Are there anything like in the
Okay, let's.
sacrum, adjacent to the sacrum, those opacities?
These ones,
Because
you mean?
no, about that, more on the
These
right
these
side we
ones.
see.
Oh yeah, these
Yeah.
ones. What do you think
Yes.
those are?
Uh,
Does anyone want to give any comment? What do you think those are?
is it just the fat?
So fat would be
It will
more
be more
more
fat. Yeah.
yes, more low density, isn't it? It's not fat. So sometimes you can have the fecal loading also can look like this, and because there is air
Okay.
around, it can look sometime like that. But
Okay.
but what I would say is, in rapids you won't have something subtle like it has to be very um, unambiguous. So for example, if you show this to 10 radiologists, 9 out of 10 should say that this exists. And I think now we have almost 10 people here, and how many of you think that's pathological? So you know what I'm trying to say. So that's how you try to judge when you're writing a rapid, like is it something only I'm picking, or is it something going to be picked up by most of them? And so that's how they screen it, the x-rays, to put it into rapid. So there are people around and they go through the every x-ray and they judge it whether that only has one abnormality, or if it's normal one, which is actually more difficult to pick because then that should not have any abnormality there. So yeah, that was a
Okay.
good question. And what are these?
Phlebolytic.
Yeah,
Central
good.
lucency could be phlebolytic.
Yeah. Okay, so we'll go on to the number 8.
Fracture distal clavicle. Right.
Okay, so is it a acute fracture? Where is a fracture fragment if it's a fracture? Does anyone want to chip in and say something? So this is not exam, so you guys can relax and speak up. That's why we are doing this. This should be a discussion, isn't it?
Looks like some cortical break is there is here in the clavicle
Yes.
superior,
Yes, but
and
what
also
is this?
inferiorly there is some bony fragments inferiorly.
Mm-hmm. So this is actually post-traumatic osteolysis of distal clavicle, because there is also osteopenia. You don't have the osteopenia develop that quickly, isn't it? Yeah. Anyone have any questions about this one? Even though you write, if you write fracture, you will get full marks. But I'm just speaking like how else you can go about it.
You can mention osteolytic lesion.
Sorry,
Osteolytic lesion distal clavicle.
we are not able to hear you properly. Can you speak up? We have with us Dr. Rai. He was run a bit late. I think he will take up from here.
Hello there. Hi. You're doing well? Okay so far?
Yes. So we have 10 candidates.
Yeah, very good.
Yes, and we are on case number 8. So I was just telling them like why this is not just a simple fracture and why this is osteolysis, post-traumatic osteolysis because of the osteopenia.
Yeah, because the resorption of the bone is there on the lateral end. There is a old fracture, but the bone is resolved and there is a, so it's not it's not normal anyway. The AC joint doesn't look normal. It has been deformed, and because of the old injury. So you can say old fracture with AC joint deformity or lateral end of the clavicle deformity, whichever way you want to say, you can say that should be fine. But the point is, it's not a normal film in any way.
Yeah. So even if you have written fracture, I think I haven't cut their marks. So
no, the main thing is if you don't know the exact diagnosis, is best is to they say that to describe the area of abnormality and write the side. So right shoulder or right clavicle, deformity of the lateral end involving the AC joint, you'll get full marks. That's what you need to do if you don't know what exactly is going on. Yeah. Okay.
Okay, we will move on to the next one then. Does anyone wants to describe it? So I'm giving them option to describe it first as a case, and then
Sure.
we're discussing it.
Okay, may I try?
Yeah, Alan.
Carry one by one.
Yeah. I see some this is a frontal radiograph of the right shoulder. So I see some foreign material, probably resembling some external fixation devices. That may be a and I also noticed there's a bony defect.
You mean these ones?
Yeah,
you mean these
clips. Yeah.
Yeah.
I suspect
They are
this patient
artifacts. They are not.
is on a arm sling. There's a bony fragment at the inferior aspect of the right glenoid fossa, and also a cortical depression over the anterolateral aspect of the right humeral head. So I suspect this patient had prior history of anterior dislocation of the right humerus with relocation complicated by heel sac deformity and Bankart lesion, bony Bankart lesion of the right scapula.
Good. Yeah, good. That's good. So that was.
This is an abnormal film, bony Bankart lesion. If you write down inferior rim of glenoid fracture or bony Bankart, you'll get full marks on the right side.
Yeah,
I see.
Okay, so we'll go on to the number 10 then. So does anyone wants to take it? Weissley has done, Shankar has done few cases. G and K can take it. Catherine can take it. Nuha can take it. Nishat can take it.
Light depletion and
I can try this. This is a frontal radiograph of the pelvis. So I noticed there's a ill-defined right transitional zone radiolucent lesion over the right femoral, right proximal femur. There's no associated cortical break. No calcification noted. There's no adjacent soft tissue mass. For this other patient, ill-defined white transitional radiolucency lesions, I will think this is aggressive lesions. My differential will include malignancy. It's less likely to be primary, so I will think about metastasis like myeloma. Other than that, infections can be also a differential. I'll correlate the clinical history, whether this patient has any signs of the infections.
Yep.
Good. So this is a good description for Viva case. The vascular calcifications are all considered normal, minor degeneration normal. Yeah, okay.
Okay.
Any questions, anybody? Okay, carry on.
Okay, so number 11. Anyone wants to take it?
The Pellegrini's the lesion over the left proximal femur.
Good.
Distal femur.
Yeah. That was a subtle finding, so that's why it's important that you guys zoom in and look at everything if you're not finding anything obvious. Yeah. So the next one.
So any question on the previous one? Anybody had any question on that? What to write?
Diagnosis for this.
Yeah, it's a Pellegrini's or you can write a bony flake, medial condyle at the metadiaphyseal junction. Yeah.
Yeah.
Yeah. If you don't know the name, yeah, you can write left knee. Okay.
So number 12, what did you guys wrote?
Majority normal. This is a normal X-ray chest. So if anybody has any question that is not normal, and then that's it. It's a normal one. All the review areas normal, everything normal. Yeah. Number.
Yeah. So next one, number 13.
Agree, normal.
Anyone has any questions about if you guys? Okay.
What we are on
number 13 is what we were on.
So that is a nutrient ferment which was queried once, and then it's all normal. And number 14 we'll move on to.
Number 14, what do you guys wrote about this one?
Is normal.
Does anyone have any questions about why this is not normal, or did you think of something?
Yeah, this is normal. We'll move on to number 15 for the sake. So this takes some time. Do somebody wants to pick up this one?
I think yeah, someone should present this. And NH, Ashwini, Nuha, does anyone wants to present?
Come back. So do anybody, or should we just say this is?
No, I think let someone. It's a good scan. I think we'll just wait for someone to present, or I will just call out. Okay, yes. Catherine, you should present this one, because I think you had picked up both of those findings, and when I was correcting it, so.
This is a frontal radiograph.
Yeah.
Of a woman. I noticed there's absence of red shadows. However, there's no some clips in the axilla. So I think these patients likely have previous mastectomy. I look for the lung. There's no focal lung mass. I noticed that pulmonary coldness appear to be prominent in this radiograph.
Good.
The pulmonary vessel appear to be prominent, especially the right inferior pulmonary vessels. There's no pleural effusion, no pneumothorax. The rib cage is intact. So for this case, I don't know whether I should write down, like for the breast, I should write down. So because I know the answer is a post-mastectomy, but I'm not sure whether the coldness that it appear to be quite prominent.
Yeah, so I think Dr. Rai will explain why there are two findings and why this is not really.
I think this is for rapid reporting. This is abnormal film. So one is mastectomy, which is also not a normal thing to be there. So it's abnormal, any operation done which is not there. And I think there is not obliquity as much to say that the hilum is quite prominent on the left side. And this can be more of a discussion. But for point of view of rapid reporting, remember that the Royal College will only keep you one finding at one time. So it could be left hilar prominence only, and they are non-controversial. But for the sake of abnormality, if there are two and you write both, or you write one of them, also you'll get marks. But in college, for the real exam, there will be only one abnormality which you can describe. But for this type of courses and all, even they are two and you write one, will still allow you to get marks. So you got it abnormal. Well, that is right. You got full marks on that. And just like it happened to be two pathologies in this. Yeah. Okay. So it's abnormal film.
I have a doubt. It's when do we actually tell it bulky hilum? Because most of the times, whenever I feel bulky and I'm typing that, and it's turning out to be wrong.
Yeah, so when the hilum is like this case, I'll remember that the hilum, the vessel comes out is concave, and this is a convex hilum. So if there is a convexity and you don't see any much significant rotation on the X-ray, like if you say the spinous process and the clavicle, they're not too far away from each other to account for that much of rotation in this case. So, so this one is more convex and bulging out. So it is very difficult to say it is normal. On the other side, you can see it's more of a convex and lack of a hilum there at all. Yeah, so this one is convex. So make sure it's convex, not concave. Sometimes the vessels are prominent, but still a concavity is there.
Also you need to look at other things when you have something like a bulky hyla. You need to see what kind of contour it has, because if it is merging with the iota and things, so you also need to separate them, whether that's a hilum thing or it is coming from the vessel. So that also need to be a bit careful about, because sometimes uh, aortic descending aneurysms and things can confuse them like that. Yeah.
Okay.
Okay, so the next one, does anyone wants to take it?
Just mute it. Yeah.
Does anyone want to take this one?
Front lateral radiograph of left foot shows a stress fracture in the left calcaneum. There is sclerosis.
Correct.
Yeah,
Very
correct.
good. Actually, this is a very subtle one, but I'm very appreciated that you guys picked it up as abnormal.
Yeah.
In the exam, you'll get a proper
No,
factual.
it's a webinar version.
Yeah.
So it's a decreased collar angle also.
Yeah. But that is due to the fracture, isn't it? Yeah. Yeah. That's correct.
Okay, so we'll move on to the number 17.
Talus osteochondral defect.
Yeah, very good.
Very good. That was really subtle.
Very good.
Subtle one. Very few of you have got it, but very subtle. Okay, so the next one, number 18. Does anyone wants to take this?
Fracture in the left capitulum.
Yes, so it's a capital avulsion fracture. Yeah.
Yeah, that's correct. This is also a subtle one.
Yeah.
And it's an immature skeletal, so it makes it more difficult because there's already epiphysis not fused. So it's extremely good, very good.
Okay, so the next one. This was really difficult one. I don't think none of you have got it. But this was really
this is abnormal film. The reason being that we don't see normal knee replacement in all day-to-day practice, and we don't know what we are looking for. We look for fractures and lucencies and things like that. But if you see 3 dots in the back of the knee, they are the pacer, which should be between the two metal. So when you do an AP view of this knee, you can see a loosened gap between the two metalwork with 3 dots. They are pacer, they are like the cushioning defect, and that has been displaced posteriorly, and the patient has a painful knee. The reason we find it difficult because we don't report routinely a lot of knee replacement or hip replacement, and reason is that. So if there was an AP view in this, it still maybe you will see it in between the metalwork because it's in the back, pushed back. So the lateral is the key to this one and is abnormal. Yeah, anybody needs to ask anything on this?
guys, any questions?
Okay, move on.
Sorry, what's the answer that should be written?
So it is a spacer displacement.
So there are, like, you can even write there's some displacement in the back or some lucency with dots in the back. Whatever you not, it's called spacer in between. Yeah, the two metalwork in the knee joint.
Also, this was a clue because he has undergone the total knee replacement, so that was a clue for this one, isn't it? Okay. Does anyone want to describe this? Because this was a simple one. So you can describe this as a Viva case maybe, if anyone wants to describe.
Can I try?
Yeah.
Yes, please. Yeah.
So this is a frontal radiograph of a right knee joint. I can see there is an exophytic growth involving the right proximal tibia that is having the corticomedullary connection with the right tibia, and it is facing away from the knee joint. So this gives appearance of osteochondroma, right tibia.
Okay, very
Yeah.
good.
Okay. So we'll move on to number 21. What do you guys think?
Yeah, so this all your review signs, no fat pad, nothing, no fracture, still some of the electron and the epiphysis yet to fuse, so it's normal, yeah?
Anyone has any question why this is not normal? Okay, we'll move on to the next one then. So this was subtle, and yeah.
So this
When we see subtle fractures like radial head, which we like not able to make out, and we see only the fat pad, can we just mention that in the exam?
Yeah. If there is a posterior fat pad, it's definitely positive because they are not normally seen. Anterior fat pad, which is displaced, is also abnormal. So if you just write fat pad prominent in the posteriorly and question mark intra-articular, maybe you will get half the mark, like out of 2 you'll get 1, but at least you'll get it rather than not calling anything. Yeah, okay.
Okay. So does anyone want to describe this one? Number 22.
So this is abnormal. There is
a soft tissue.
There is a soft tissue which is leading towards abnormality in the lateral malleolus, and there is a fracture line transversely going to the lateral malleolus. So this is a undisplaced fracture lateral malleolus with surrounding soft tissue swelling. So you mentioned altogether right ankle, yeah? Soft tissue, fracture, all the leading signs also should mention, so that is good. You don't lose any marks.
Okay. Move on to the next one. Does anyone want to describe this one?
Right acromioclavicular dislocation.
Yes. Agreed.
Yeah, so there is a AC joint is not normally aligned, is inferiorly. Normally you get a pointing upward, so this is inferiorly displaced AC joint and is subluxed in dislocation of the AC joint on the right shoulder. Yeah, okay.
Okay. We'll go for the next one. Does anyone want to describe this as a case? Because you can get this as a Viva case, isn't it?
Yeah.
There is displacement of the left femoral head, left slipped capitate femoral epiphysis, left-sided.
Yeah, correct. So this is like obviously tilted internally and medially. The left one epiphysis, the growth plate is narrowed compared to the other side because displacement. So this is typical Sufi left hip.
Yeah. Number 25.
So this is one of the normal variation, guys. This is a very well corticated defect, no fat pad sign, and this is a normal variation, which is split cleft epiphysis of the radial head. Yeah, which is a cleft because it's all sclerosed, very rounded, and no fat pad. So this is and it's slightly dense also. So this is a normal variation, which is a normal thing. Yeah, for exam point of view.
Any questions, anyone? Okay. Move on to the next one. Number 26. This was again normal one, but I think some of you did mention about something like Paul gas. Some of you were going on about degenerative changes, but those are normals, degenerative changes and other things. So yeah. Does anyone have any questions about this one? Why this is not normal or something like that?
Yeah, this is normal. That's a joint normal and spine is normal. Yeah. Minor osteophytes are normal. No past defect. Look for past defects and all in the for rapid reporting. That's the main of your review and SI joint. Yeah.
Okay, so we'll move on to number 27. What do you think this is?
Normal.
Yeah, this was again normal.
It's completely, yeah. Pantomogram normal. No TMG problem, nothing erosions, no bony lytic lesions. It's normally in this type of X-rays you can get fractures or a lytic lesion in the mandible. Yeah, okay. Nothing there.
Okay, next one.
Again, a normal spine. 28. Alignment okay. Pedicles you can count okay. The ribs are fine. You look behind the heart. Paraspinal rhine. These are your review areas when your spine is given. Paraspinal shadow, calcification, retrocardiac, posterior transverse, costotransverse articulation, fracture ribs in the back, and displacement height. So they all look normal. Yeah. So any fusion or something on the lateral view. So this is normal. So moving on.
Yeah.
So this is a abdominal X-ray. Shows normal gas pattern because of fecal loading and normal IUCD is normal. No gas abnormality, no obvious calcification. SI joint is okay. Hip joints are okay. Okay, this type of rotation of the spine, this is they're not going to give you for rapid reporting like that. This is slightly positional, so don't have to worry unless it's very obvious abnormality.
Yeah. But copper T is normal, yeah?
Yeah.
Okay. Next one. Do you guys have any doubt about this one?
This is again, the last one.
Again normal.
We kept it as normal because alignment of the shoulder, coracoid, bony greater tuberosity, AC joint, medial clavicle, ribs, no pneumothorax. So look for pneumothorax in shoulder X-ray, guys. Very important. They can be given or a solitary nodule in the lung. So you can be missed out with the shoulder. So look for that. Supraspinatus calcification or soft tissue tendon calcification are abnormal. They may not keep in exam, but they are abnormal. So think about that. And as we saw the AC joint one, two X's with AC joint, so things like that. Okay.
I think we will go through them just the diagnosis because many of you joined late. So I will just read out what was the diagnosis in each of them. So this was the first one where there was a lytic lesion on the left side, superior ribeye. This had the avulsion injury of the patella. If someone wants to shout out the answer, that's also fine. The distal phalanx had a fracture, and that was an old fracture. So I was telling them that usually they won't get any case like that with the two abnormalities. Yeah. So this, I think someone described this well as osteomyelitis as a differential. That was really good. Some of them have written fracture as well. I think they will. Yeah. Oh, so just the normal fracture will not get the mark. Okay. 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 So this one again, fracture. I think this is also pathological fracture, isn't it? Yeah.
Most likely metastatic deposit for viva cases.
Okay. Next one, this 6th and 7th were normal. 8th one was post-traumatic osteolysis, demodeling AC joint, yes. 9th one was Bankart. Number 10 was lytic lesion here, Pellegrini stidi lesion. This was normal. Number 12. Number 13 was normal. Number 14 was normal again for the foot. So this is what we were telling you guys in our YouTube video as well, that sometimes you can have multiple normals in a club and multiple abnormals. Yeah. This was right mastectomy with lymphadenopathy. Usually you will get only one. This was a subtle one, calcaneal fracture, stress fracture. Number 17 was osteochondral defect there. Number 18 was avulsion capitellar. Number 19 was spacer displacement on a knee replacement. Yes, that's how, in a left knee. Number 20 was osteochondroma. 21 was normal. 22 had a soft tissue with a fracture there. 23 was AC joint subluxation or dislocation. Then you have left SUFI in 24. 25th was a normal variant, cleft epiphysis. So many of you wrote it as a fracture, but that's normal variant. So you guys should know what are normal variants as well. Yeah. 26 was normal. 27 was normal. 28 was normal. 29 was normal, and 30 was normal again.
So you can see that there was about 1, 2, 3, 4, 5, 6 normal.
6 normals in a given row. Yeah.
So that's why you have to be careful. It doesn't matter in exam. It will be how confident you are. So for this, we just gave it like people who will look at it later on can see the diagnosis together with it. And the reason is like, rapid reporting is very important. It's one of the weakest link in exam, and I hope that this will help you guys get some ideas about the rapid reporting.
Also, we are conducting course next week. If you guys want to register, there is a link in the group. And if you guys have any doubt about rapid reporting, we are here for I think 5 minutes.
That's fine. So the course is designed for really for June exam or people taking in September, just for a proper last minute shot for the exam with long cases, rapid and viva station like 1 hour. So that is where this is designed for. If you are interested, it will be good. It will be on the DICOM. You can write the answers as you do in the exam. So it is exactly the same pattern. So make sure that if you're really interested, just tell us.
Yeah.
And we will accommodate you guys.
Yeah.
Because we are here trying to help you guys who are taking the exam. So this rapid is the main thing in rapid is make sure that you report like you are reporting normal life X-rays, like in the A&E hot seat any report. Don't take it very seriously. Take it as if you are doing reporting normally, because there is a good statistics that people overcall the films rather than undercalling. So because the only downside in rapid is you don't get the clinical history when you get in normal life to day life. So that is the only thing you don't know where you're looking for. And as we said in our tutorial, that gut feeling is mainly important.
Yeah.
If you think is normal, the film is normal, and make sure the exam is very clear and precise films. They have been vetted by a lot of other consultants, so they are very non-controversial. And hope you guys must have got 27 and over in this one to make you feel.
Unfortunately, not. I think only one person got 27. and few got 26.
Yeah, but even 26 and
Yeah,
25
few.
and over are quite a good promising sign here, isn't
Yes,
it? Yeah,
agreed.
So I think.
But you guys should practice more in rapids, because that is like a make or break, isn't it, in exam for many of you.
Okay.
So yeah.
Did you like the DICOM? I hope you like the DICOM. Put a comment if you think the DICOM version or your rapid reporting was the software was good, because we would like to give more of this rapid reporting on that platform, whether it's helpful in that way. It was.
Please find the link for the future Radiology University courses below. Join our WhatsApp or Telegram group to stay updated about the release of new videos, Viva tips, and monthly free FRCR Viva sessions. Oh, and I almost forgot, find our free book about FRCR 2B tips in the link below.